Good morning, everyone. I'm truly honored and privileged to be here with all of you today. And I'm very thankful and grateful to Ms. Francesca Serreta for her marvelous assistance with this workshop and, of course, her outstanding contribution to the coordination and work of the geriatric expert group. So for me today, my task is to present a brief overview and set the stage of what we know about some technical and practical issues that relate to drug use in the elderly population. And as such, we might think that this is not very scientific. We are all very familiar with clinical pharmacology, pharmacovigilance, regulatory procedures. So basically having a formulation ready to use in a cabinet is not something that we consider very scientific, but it is, believe me, it is embedded, the pharmacology science and the end product appearance of the drug is something which interrelates with each other. So these very practical problems that the elderly population face with the drug use are tracing their roots in the design of the drug and the pharmacological qualitative characteristics of every modulation, every therapeutic modulation that we're using for the elderly. So what do we really know? What are the current facts about drug use in older people? We might somehow forget that the number of drugs that are used increases almost linearly with age. And there's a lot of evidence and clinical trials and other evidence in the literature indicating that older adults use an average of 2 up to 6 prescribed medications and 1 up to 3 non-prescribed medications, which constitute up to 30% of all prescription drugs and almost 40% of all over-the-counter medications. At least 80% of people aged over 65 are using 1 or more drugs on prescription. More than 40% of the elderly are using 5 or more drugs each week. So the process of aging, the high prevalence of comorbidities, the large number of drugs used, and the complexities related to the use of medicines in this population constitute a solid basis for trouble, because it's nice to figure out what an appropriate prescription is doing and what are the facts we know about it, but even the most appropriate medication, even under the most proper circumstances, will provoke a result, will make itself efficacious only if used at the proper way. So this is literally linked to the way the elderly population, especially the elderly population, is trained and ready to use the drug. And why is that? Why are formulations and packaging important? For 2 major reasons. First, because they directly impact upon impairment of or modify conditions seriously affecting the ability to take medications, even to take medication, and more specifically, first of all, to remember what and which medication, when, where is it stored, and how to use it. There are people who have, with cognitive impairment and other disabilities, that don't even remember and cannot even understand how to use the drug. Secondly, how to reach it. It depends where it's stored, how far from the bed, how far from the natural habitat of the patient. Okay, there are overall mobility impairments, frailty, and arthritis impact largely upon the ability of an elderly individual to reach the proper drug. Even to see which pill or which drug to use because of visual impairments and cognitive decline. To open the container requires manual dexterity, not necessarily straightforward to an elderly individual, and of course, certainly impaired in many musculoskeletal disorders. The ability to even swallow, especially liquids in the elderly, greatly contributes to the quality of the result we expect with a given medication. first of all, because of taste aberrations and the concurrent existence of sialorrhea, xerostomia, and dysphagia. And of course, there's an ever-increasing inability of many people, especially in this section of the population, to acquire, to pay for their drugs. And there are some people in lower socioeconomic classes that would rather eat something than acquire a drug, because it's good to say all this tremendous scientific evidence that we all are familiar with in this room, but all this translates to the accessibility of the wonderful medications we propose to people. And for example, because I work in Athens, Greece, in this period, it's very hard to convince people not to mention, job losses and all this kind of income cuts, and to urge them to acquire more expensive medications or to implement telematics and software or electronic diaries to adhere to formulations. So this is inherent problem in the elderly. Now, as a second line of why formulations and packaging are important for the elderly is because they actually cross-react synergistically or antagonistically, directly or indirectly, with factors influencing pharmacokinetics and or pharmacodynamics, and thus directly predisposing to adverse drug reactions. We all know that gastrointestinal qualitative characteristics, and especially motility, is a prime factor that determines pharmacokinetics. Malnutrition, the state of hydration, and those adaptation-related formulation modifications that have to do basically with body weight, renal, liver, and heart insufficiency, and altered cutaneous physiology in terms of transdermal applications. Of course, the underlying disorders and comorbidities, an issue that has been tackled very successfully yesterday and today. Polypharmacy, the ever-present polypharmacy. And of course, other socio-cultural, economic, and psychological distress issues that are not to be forgotten in this particular section of the population. So how do we improve the patient compliance and adherence to a specific treatment? First of all, we have to understand that geriatric populations require specifically tailored formulations. If individualized medicine has to play any role, individualized geriatrics is even more important. Now, older people, we have to understand that they often self-adjust doses and frequency in response to many, many environmental triggers, neighborhood habits, and their own particular assumption of how treatment should be. So appropriate packaging or information or repackaging is of paramount importance for the elderly individual to understand exactly what the drug is doing and where to find it. For gastroprotected drugs, of course, this cannot relate to a very large tablet. Color and shape recognition, especially in generics or substitution drugs, has been proposed as an alternative to help individuals to reach their medication of interest. Innovation and smart formulations, for which Dr. Gudmundsson will give you a brief layout also, are important. And of course, adaptations to or reductions of pill burden to enhance compliance and improve safety. How does the physician, the pharmacist, and the healthcare provider in general could initiate an approach of this problem? By prescribing combination drugs or long-acting forms, by trying to make the individual having fewer pills to remember, to often reevaluate medications, especially when there's a new treatment initiated, to encourage patients to use one pharmacy, because usually pharmacists, experienced pharmacists, could trace back the therapy habits of a patient, and of course to always encourage follow-up. How about medication aids? We should remove the cotton packing, store in original containers, some practical information to keep the drugs in dry place away from heat and light, to always follow the instructions, to get rid of outdated medications, to avoid sharing medications, and for those with vision problems, to have large print labels and color-coded labels. How about polypharmacy and drug formulations? What can we do to lessen the impact of polypharmacy? We need to mostly use a fixed dose combination drug products. Of course, there are some clinical pharmacologists here, including myself, who are not very fond of this approach because, of course, in special populations it's applicable, but there are other individuals that you cannot actually do the same thing with one fixed combination. Long-acting active ingredients is an alternative. Sustained release or extended release formulations when appropriate. We should also consider alternative routes of administration if appropriate. And of course, to consider non-pharmacologic alternatives or interventions when we have special problems in specific patient populations. I would now like to invite Professor Gudmundsson from Geriatric Department at Reykjavik University Hospital to assist with this presentation by presenting you some significant take-home messages and some recommendations. Adalsteinn.
Thank you. Great to be with you all here. We split the talk and we split tablets now. The pill splitting, I think that's something we should pay some attention to. You heard the phrase start low, go slow. You might also add, stop slowly. It applies to many medications among the elderly that we need to stop them gradually. Think of also the history of drug marketing and drug development. The history proves itself there that the elderly, they are prone to needing lower doses. Think of atenolol, for example. It first was marketed in 1976, and the first dose marketed was 100 milligrams. Then they became 50 and then 25. I contacted a pharmacy in Iceland lately that is distributing to older populations in nursing homes and in home care, and about 10% of their atenolols are split at 25 milligrams. So how about mainland Europe? I found a recent paper from, this was a study done in Saxony, it's a federal state in Germany, and they surveyed the patients of primary care physicians. Mean age was about 67 years old, and about half of the patients, they split one or more drug. And notably, almost 9% of the pills being splitted were unscored. So that's something to think about. There are federal agencies, such as the FDA in the USA, that have specifically warned against this practice, and so have some professional societies as well. So how about the nursing home environment? Yesterday, there was a comment here at the roundtable talking about technology. So having heard that, I decided to put in this slide, add this slide in here this morning. A rather complex slide here, but it takes you through the process of drug treatment within the hospital. Many opportunities there to make improvements, but I point you out to the lower right here of the slide. You see that almost 40% of serious errors, they have to do with administration. So what does that have to do with formulations? I take you to this recent study performed here in the UK, and they specifically looked at delivery systems. And you can see here that by giving liquid formulas, the odds ratios are markedly up 4. Look at the inhalers, that's more than 30-fold, but the confidence interval is pretty big here. But inhalers, half of them were given incorrectly. So think about that. Think about dementia, the neuropsychiatric complications of dementia. That's a very large task among geriatricians. So that part is growing. The new medications, promising agents for stopping dementia, particularly Alzheimer's, they are not that close by. So we will be dealing with complications of dementia for years to come. Think of alternative forms in dementia, even covert administration. Having a dementia doesn't necessarily take away the decision capability, but it's a gray zone that you have to covert the medications at some time. Crushing of pills is particularly common in nursing homes. and which is quite a concerning practice. Has potentials of only partial administration. You may lose some of the ingredients. You can have interactions. There can even be health hazards to staff, and administration through feeding tubes is a particular issue I will not mention here, but that requires special attention as well. Dysphagia, common among geriatric populations, has multiple causes, but is certainly something to be aware of here, talking of formulations and dosage forms. Somebody mentioned here before nutrition. There is a rather large but uncharted overlap between dysphagia, taking drugs, and malnutrition. Hospitals, they are really heavily structured towards giving medications, but we often forget nutrition. We heard a cited paper yesterday about the elderly losing muscle mass faster than younger people in the hospital. Perhaps it could be partly due to nutritional aspects. I just wanted to point out a few special aspects. Palliative care is a widely defined term, but that certainly poses some challenges for alternative ways of giving medications. We lack information of the same drug given in different formulations when you switch from an oral pill to a liquid formula and vice versa. And the issue of interactions between dysphagia, malnutrition, weight loss, I think that should be part of future tasks as well. I know that the red sign is around the corner, so I've skipped the take-homes, but I would welcome some comments here afterwards or questions if allowed.
Are there any burning questions to our speakers on formulation and packaging aspects just now? Yes, the gentleman over there.
Yeah, I would like, Wim Wientjens, International Diabetes Federation. I would like to add to you that because of stressing the side effects of medicines and the negative side of the medicines, there are even people with diabetes who are giving half of the doses of the prescribed insulin because the people are thinking, yeah, drugs are not good for me. So when I take half of it, then it will be better.
Well, I would say my comment would be the patient is often correct. What happens in the hospital is that we give the presumed dose. That can be quite disastrous.
Please, yeah.
Yeah, Lisa Murphy-Urardis. I think it's very important what you talk, the connection between malnutrition and the drug, because it can be that the side effects, for example, causing nausea, etc., prevents people from eating if they take the tablet beforehand, etc. And I think those areas are not really covered, particularly also I think about risk management plans. So there is a lot of gap of knowledge there, I feel. I don't know if you feel the same.
I totally agree with the comment.
He's over there.
Thank you, Adalsteinn, for your nice presentation. Also, Michael, just a small comment. I would like to place a kind of question mark beside long-active ingredients. They were proposed by Michael, but I think that we should be very cautious with long-acting ingredients, particularly under conditions of limited compliance or in nursing homes, in situations where these pills are sometimes crashed, and in that moment they can produce very serious adverse effects.
Yeah, thank you.
So I won't be in favor of long-acting products in our frail patients.